Again, thank you everyone for being here at these early hours and so many halls going on. So I will be talking on how intersegment imaging helps in post-anti-glaucoma surgeries. Trabeculectomy is still the most effective filtering surgery, even though more and more surgical options and MIGS are now available. And the long-term data shows efficient control of IOP up to 67% of initially successful trabeculectomy after 15 years. So in the follow-up care of these patients, the ophthalmologists focus on the bleb as a functional part of the trabeculectomy. Various useful classification systems are developed to identify the filtering bleb according to the morphology and parameters can assist the clinician in decision making, but the clinical evaluation of this patient can be challenging. So this is to show you the natural history of the bleb, what happens. So earlier in the first, after 3 weeks or 4 weeks, it starts showing the failure if it is there. By the end of 3 to 6 months, it is stabilized and then it is status quo. So bleb morphology is known to be an important indicator for the bleb function. Morphil classification every one of us are using. It describes the area of the bleb, height of the bleb, and vascularity. The Indiana bleb morphology classification has also included the leaking or the Seidel test. And the AMBAGS classification not only see the height, vascularity, but also describes the transparency of the bleb. And this all will help us in guiding which are going to be a successful blebs. So the imaging of trabeculectomy bleb is not a new thing. It's been using AIOS2025 for this, and it is a promising tool to imaging the trabeculectomy bleb in a very early stage of the operation. It was able to demonstrate the features of the bleb morphology which are not visible with the slit lamp. So assessment of filtering bleb in vivo or the functionality is possible using this technology. This is a classic section to show you AS imaging of the bleb. Here you can see the subconjunctival fluid space, wall bleb, a wall of the bleb, then the scleral flap here, sclerotomy opening, and the root beneath the sclerotomy flap, iridectomy, and suprascleral fluid spaces. So I will describe all this in the later part. So ideal bleb should be good if it is a vascularity is similar to the surrounding conjunctiva. It has to be have numerous microcystic areas. It should be diffuse and with a moderate elevation. This is the slit lamp picture, and it is better you visualize if you use the AS imaging. So similar looking blebs on the slit lamp can have a different presentation on the AIOS2025. This is a spongy liquid bleb. This has a big aqueous areas and a thin cystic areas in this area, and this is also having different morphology. Sometimes this avascular, moderately elevated bleb looks like a good bleb, but it is deceptive. This bleb has a very dense homogeneous area, and these are the blebs which may not have a good functionality. So vascularization and fibroplasia in the subconjunctival area and or the episcleral space are one of the or main cause for the bleb failure, and sometimes it could be the obstruction of the internal ostium. So coming back to the first slide, can we predict this bleb failure? Can we recognize it early? Can we prevent by diagnosing this early and manage it in a better way? So the most important step in the management of failing bleb is to recognize its presence. And for this aim, we conducted a study to correlate the morphological feature of bleb on AIOS2025 at 1 month with the bleb functionality or the surgical success at 6 months. So what we did post-operatively, we took the 2 sections, radial sections and tangential structure at the most elevated area of the bleb away from the limbus. The bleb wall reflectivity was identified. Uniform reflectivity is shown here. And this is the multiform bleb wall reflectivity, which has a multiple tiny cavities of aqueous drainage. Hyperreflectivity is suggested in a form of dense white area, which is not good for the success. Now, multiple bleb wall reflectivity is again identified into multiple internal layers, subconjunctival separation as shown here, or microcyst areas. And these are the blebs which are ideal for this success. Root beneath this scleral phlegm has to be identified. Now, at the conclusion of our study, we identified various patterns, bleb patterns, microcyst plus multiple layers, microcyst with the subconjunctival separation, only microcyst and uniform blebs. And it was obvious from our study that this is the area which has 100% success at the end of the 6 months. So we can predict at 1 month for the long-term success if the bleb wall with the multiple reflectivity shows increased chance of the success at 6 months. Bleb pattern with the multiple internal layers and microcyst could be ideal for the success of this success. This is a Japanese study. They also are having the same criteria, but they also included the width of filtering opening seen on the AIOS2025 as a success. Now, two eyes bleb may behave differently. This is a left eye bleb and this is a right eye bleb. So, in early case, this is one case where at the end of 10 days, patient showed rise in the pressure, 14 millimeter of mercury, and the bleb appeared to be flat. So what we should do? Do we remove the reusable suture? And this is the OCT finding showing you homogeneous area. So we release the bleb, and immediately you can see there is a multicystic formation, elevation, and this is how we have a successful trab. So, but with the mitomycin C use, we know there are so many problems. So we need a safer option. So biodegradable implants collagen was there, not now, which is leaving in its place a fibrous sponge, the negative copy of the original one by the 19 to 180 days or more. So we studied this also. So this is a homogeneous implant seen immediately after the surgery. And at the end of 6 months, there was a complete absorption of this implant. So this is day 1. There is an anoic area here, and this is homogeneous implant. After 3 months, you can see the shrinkage of the implant here, and new areas of anoic space is coming up here. And at the end of 6 months, there is a total shrinkage with a large anoic area in this subscleral space rather than in the subconjunctival area, and few microcytic space away from this homogeneous area. Expressions, you can identify where exactly is the position, and you can evaluate the bleb. The tenon cyst, this is what it was with the 26 millimeter of mercury and 2 millimeter height. And after needling, you can see the flattening of the bleb area. At the 6 months, still there was a single cavity, and cyst size was 0.6 millimeter. You can also identify the positioning of the tube, where exactly it is, away from the iris or the cornea, or exactly you can localize the pathway. So implication is, for the better understanding of the bleb morphology, you can predict the failure or success at early postoperative period. So you can use either early intervention in form of enhancement of steroid, 5-FU or MMC injection, needling, and release the suture. So limitation, vascularity of bleb and leaking cannot be identified using this technology, and difficult in children. So it is useful modality for evaluating the natural history of any implant that you are using or predicting long-term success. Thank you.
Thank you, Mayuri, for wonderful photographs of the various